Assalamu alaikum to all of you. I was unfortunately not able to record my presentation, which was the first talk on GDP, but I'm just going to go through the slides and just talk through the things which I've spoken already. I do apologize, we won't be able to, we've passed the panel meeting, so we won't be able to record the panel meeting. So this topic today, we're going to talk about pulp pathology and management based on the ESC guidance, updated guidance for management of deep carious lesions in the tooth or teeth. So just a moment, please. Yeah. Primarily, most of us try to come to a conclusion based on the patient's symptoms and signs, and we are very hesitant to start drilling the tooth and commencing root treatment. Unfortunately, we shouldn't do that because we have to take a slow approach in order to try and retain the vitality of the pulp. Classifications, we have issues with classifications. Most of the time we tend to be confused because we have loads of different kinds of classification of the pulpal condition. We've had predominantly textbook classifications based on a lot of things, but primarily what we must understand is that everything we do is clinical based. So you go through the patient's assessment, patient response, rather than the actual state of the pulp, which is basically the actual proper vitality of the pulp. There was a classification which I found to be most confusing was Abbott's 2007 classification of pulpal diseases. Honestly, I just couldn't go through it, and I find it to be really, really confusing. Now, the ESC position statement on management of deep caries and exposed pulp has a few key factors. The primary factor is preventing of apical periodontitis, which is nothing but inflammation at the apex of the root. So we want to prevent that from happening. If we try and prevent that, we will be preserving the healthy state of the pulp. And the way we're going to prevent it by using minimally invasive procedures. Minimally invasive in the sense we don't just take a fast drill and start drilling in and treating the tooth. We check and slowly excavate the decay before coming to the base of the problem. And then the use of biomaterials for pulp capping, like mineral trioxide aggregate, which is MTA, or biodentine, two most recently and most widely used materials, or calcium hydroxide. Unfortunately, calcium hydroxide is still considered to be very good. However, because of its physical properties, it is not considered to be as stable as the other two. Pulp exposure. Now, pulp exposure is classified or termed in two categories. One is the class 1. Class 1 is what we cause or by trauma. There's no evidence of clinical caries on that tooth, but the tooth could be exposed, the pulp could be exposed because of trauma, or because of iatrogenic errors or operator errors, where as I said, we need to be patient when we're drilling into the tooth. But if we start drilling too much, we might end up exposing the pulp. And if we start drilling without control, we might end up exposing the pulp. And then you got the class 2, which is 99% of the case, dental caries to the pulp, which is clinically or radiographically seen, and it is pretty close to the pulp. Now, as I mentioned, various authors have provided the classification, but the American Association of Endodontics 2013 classification still is acceptable. It's very simple classification. They've classified it as normal pulp, basically asymptomatic, normal tooth with no problems. And then you have reversible pulpitis, which obviously is symptoms which are very short duration, which are stimulated by a few things, which after the removal of stimulus, it subsides. And then you have the irreversible kind. Now, most of the diagnosis we carry out is through clinical tests, and most of them we assess the neurological state of the pulp, not the blood supply, which is what is vitality. So the neurological status of the pulp, it elicits the response from the core fibers of the pulp, and it's not the blood supply, as I mentioned. So it's always better to term them as pulp sensibility tests. Now, when you're treating the patient, you need to take all these factors into consideration and then plan your treatment. So when I was talking about reversible pulpitis, it could be a symptomless tooth or minimal symptoms, short duration of pain. If triggered, does not last long, and once the stimulus is removed, there's no pain. So it could be hot, cold, anything, food, anything can trigger it off. Then you have irreversible pulpitis. Now, irreversible pulpitis is persistent pain, spontaneous, radiating, stays on even after removal of stimulus. Some papers suggest, the stimulus can stay, the pain can stay on about 5 to 10 minutes, extremely, debatable, because you still don't know whether you need to treat. You could just go blindly and say, okay, let me just drill it because the patient's having the symptoms. Remember, pain is subjective. So you have to tread very carefully here. Seltzer et al. In 1963 said that irreversible pulpitis can be symptomless in 16 to 60% of the cases, which means it could be chronic. Your body is capable of dealing with it, and your body is capable of taking pain. And eventually your body is capable of rejecting the tooth once the pulp is dead as well. So it could be a chronic scenario where your tooth can be symptomless, and it could stay like that for a long time. Diagnostic aids, you've got a lot of diagnostic aids, but the most common we use is the radiographs. Now, personally, the long cone periapicals, preferably using 2 angulations. You can appreciate the anatomy and appreciate the periapical changes. So you need to use the holders. You need to use them at 2 angulations, and you would be able to appreciate what exactly is happening in with the tooth. Now, you could differentiate the size of the lesion. They've termed, the terminologies used is deep caries and extremely deep caries. Now, this is again, quite debatable, but when you have deep caries, this is caries extending into the inner quarter of the dentine. In simple terms, there is some layer of dentine present between the caries and the pulp tissue. So there is a risk of exposure, probable risk of exposure, but not definite. So you could clean it and you could still find some hard dentine before you could place your restoration. Extremely deep caries is when there is an entire dentine and the pulp, the caries is extending deep into the dentine, and pulp exposure is unavoidable. In this case, you would inevitably end up exposing the pulp. Now, again, on the radiograph, you could see, it's very, very feeble. The line is, there could be a slight denting, but it's very feeble, but you'll still end up exposing the pulp. Now, OPGs and or DPTs, I personally would not recommend them because they only attract radiation. They don't give you a specific picture of that tooth. Drawbacks of radiographs, they say the periapical changes aren't visible at an early stage of the pulpal condition. So that's one of the drawbacks. I think there was a study, some comparative studies which showed that CBCTs, if you take CBCTs, you can see periapical changes at a quite early stage. And they said that, I think they thought about over 80% of the time you're able to see it. But with periapical radiographs, it's about 60 to 67% of the time. This again, you have to be very careful because CBCT, you have to use it as per the guidelines, and it's very rarely indicated due to the exposure parameters and other things. The other tests you've got, the best chairside test is the thermal test. Now, you could use a cold test, which is preferably something I like using because of obvious reasons. It has a reversible effect on the pulp tissue. And then you have the electric pulp tester to second it. And I use them simultaneously. Now, Chen and Abbott, 2011, found accuracy of nearly 97% with cold and electric pulp test, and also the flumetry. Now, flumetry tests are primarily to check the vitality of the pulp. Not all of us have it in our clinical scenario or our clinical setup. So I think we can rely on cold tests. And maybe if you have an electric pulp tester, you could use the both. Now, please don't use ethyl chloride because that is absolutely useless. That's not going to help. You need to get minus 50 degrees or 45 degrees carbon dioxide snow, which is far better. Now, hot test has low accuracy compared to these. So that's why there's a preference for cold and electric pulp testing. Reeves and Stanley in 1966 in their suggested that pulpitis is seen throughout the progression of caries. However, severe signs of inflammation are only noticed when the caries demineralized. When the carrier's demineralized dentine is close to the pulp, with the risk of bacterial entry into the pulp, which basically means that the moment caries, the tooth has got a bit of caries, the pulp starts to act, the pulp starts to react, starts to repair. Now, when it starts, so you can imagine though, it still has those stem cells which will start laying down tertiary dentine throughout your life. So if you see caries at an early stage, it's better to restore it and better to prevent it. Now, if you see the caries extending deep into the dentine, then you'll have to plan accordingly. But if you see then caries going into the pulp, then there is a risk of bacterial entry. You might end up doing root treatment. So a combination of all the diagnostic aids will help in arriving at a provisional diagnosis, and then it'll help you coming to the, plan a treatment for the pulp condition. Always remember, symptomatic or asymptomatic periapical periodontitis or chronic periapical periodontitis should proceed over the underlying causative factor. So the causative factor, as we spoke, before, could be you should ascertain why the pulp has been diseased or exposed or inflamed, and that should be your primary causative factor. Now, how do you do the management? Always do it under sterile condition. Use a rubber dam. A rubber dam, I personally would use a rubber dam for any of these. If I know that there's going to be pulp exposure, the rubber dam is a must. You take a detailed pain history, symptoms, and clinical tests. All these things, which I keep repeatedly saying, is because we tend to jump to conclusion and start drilling in to do the root treatment. So let's not be hasty. Let's take it slowly. Now, when we talk about the first thing is that indirect pulp capping. Now, you could do stepwise excavation of caries, either selective removal or non-selective removal of carious dentine. Now, stepwise excavation is slow removal. You could use a slow round burr to remove the caries around on the peripheries of the cavity, and then slowly but remove affected and infected dentine, and then once you come to the brown affected layer, you could slowly start using a spoon excavator. Now, once you've done that, you should place a biodentine MTA, or in some cases, glass ionomer is also indicated, and then restore the tooth with a permanent restoration. Now, when we come to direct pulp cap, let's imagine that the decay has reached so far into the dentine that it's inevitable that the pulp would get exposed, or for that matter, when you're excavating, there is exposure of pulp. What we need to do in this case is you could either carry out partial pulpotomy, which is removal of the coronal pulp, basically using a fast handpiece with a round burr. You start removing the diseased pulp until you come to some really soft flesh of tissue with no bleeding. Or you could also do pulpotomy, where you remove the complete coronal pulp. Partial pulpotomy is part of the coronal pulp. Pulpotomy is removal of the complete coronal pulp. Once you achieve this, you need to try and stop the bleeding, and lots of papers suggest to use cotton pellets soaked in 0.5 to 5% sodium hypochlorite or chlorhexidine 0.2 to 2%, but I personally prefer sodium hypochlorite. Please do not use a needle to start poking into the pulp, because that would you're inevitably going to ruin the pulp tissue. Once you've achieved a sterile field and everything is clean, you could place a biodentine or MTA. Now, the only thing you need to do is to read the manufacturer's instructions, especially for MTA and biodentine, because you might have to wait until the material hardens or sets completely. So primarily, the best thing to do is to read what material you're using, see what the manufacturer suggests. Personally, for biodentine, they suggest 48 hours. So what I would do is place biodentine and then place a temporary filling of a glass ionomer before I call them back after my next appointment, where I remove that temporary filling of glass ionomer and then use a permanent restoration of composite on top of it. Some authors do suggest you can place the filling straight away. For that, you'll have to protect that biodentin with either resin modified glass ionomer and then put composite on top of it, which can be done. But all these things you'll have to read and abide by the manufacturer's instruction, because these materials are quite, I would say, technique sensitive, but they are easy. The reason MTA is preferred over calcium hydroxide is because of its physical properties. It's stable, it's a lot more stable than calcium hydroxide. And because of its stability, that it stays in one place once it's set, it can release calcium slowly into that affected area, thereby leading to reparative, stimulating the pulp cells or the stem cells and causing the formation of reparative dentin. Now, if you know that the tooth is for surely completely dead or devitalized, then you'll have to do the pulpectomy procedure or the conventional root canal therapy. If I have to summarize all of this, you'll have to just look at the things when you check the patient and the tooth. Most of the diagnosis is inconclusive. If there is no conclusive diagnosis on your part, then I would suggest you monitor the tooth until the symptoms are specific or the symptoms increase. All teeth need to be followed up 6 to 12 months, up to 4 years, with radiographs and pulp tests. Now, success depends on patient's absence of symptoms and absence of periodontitis in the follow-up x-rays. Sometimes you might find that patients might not respond to pulp sensibility tests. Predominantly, if you carry out the pulpotomy procedure where you remove the coronal part of the pulp, then they do not show any response to the pulp sensibility test, and you might have to rely on radiographs and patients' symptoms or signs. So if on radiographs you don't see any form of changes at the periapical region, then you could keep monitoring the tooth. But if you do see some changes, then unfortunately you might have to initiate root treatment or root canal therapy. Now, evidence suggests that most pulp cap procedures have 80 to 90% success rate. Now, this again is multifactorial. You could find people of a younger age having a higher success rate than people of an older age, but you don't have to do pulp cap procedures on people who are generally old, because you might not find much of pulp tissue. If the pulp status alters, as I mentioned, you might have to treat them suitably. Now, always remember, there is the undifferentiated mesenchymal stem cells inside a healthy pulp, and they can regenerate. So please try and retain the vitality of the pulp. And if you have any further doubts, if you think there is a doubt on that case, please refer further to an endodontist or somebody who is specialized in this field. There's no harm in taking a second opinion or trying to help the patient in getting better treatment. Well, thank you very much for listening to me, and I'm hopefully I have satisfactorily spoken everything I spoke on the original talk. If you have any queries, you could please post it on our group, and we could carry the conversation over there. Jazakallah khair. Thank you.